I was in the clinical trials of iStent before it was FDA approved, but we've had it since FDA approval about 2 years and a few months ago. There's really not a technology that's similar to iStent on the market. It really kind of launched this category of microinvasive glaucoma surgery. You could make an argument that endoscopic cyclophotocoagulation or trabectome are MIGS procedures, but I really think that the iStent is probably in a category by itself, and I think that seeing the numbers of these different types of cases that are done would confirm that. There's a huge gap in what we can do for glaucoma patients. Medications aren't benign and they're not easy to take. Trabeculectomies and tube shunts are a rough surgery, and the best data that we have on that is the tube versus trab study showing that 50% of trabs fail at 5 years and 35% of tube shunts fail at 5 years. And so there's a lot of risk that comes with those, but there's a lot of patients that need something in between there, and a lot of patients that really wish that they weren't on their eye drops. I think the iStent has given me an ability to take care of patients that have got mild glaucoma, moderate glaucoma, sometimes even early severe glaucoma, and prevent them from needing more surgery or help me get them off their eye drops and protect them from their glaucoma better, no doubt. I've used the iStent probably 85% of the time I'm doing it in kind of an on-label way with cataract surgery, but probably 15% of the time I'm doing either 2 stents or in a pseudophakic or occasionally even in somebody that's phakic. So always for glaucoma, but not always combined with cataract surgery. The iStent is tiny. It fits in the ridge of a fingerprint, the smallest device ever implanted into humans, and so it's technically kind of challenging, especially when you first start. It's about 1 millimeter long and 1/3 of a millimeter deep, and you put it right into the trabecular meshwork, and that bypasses the high resistance outflow of the trabecular meshwork and lowers the eye pressure. The safety profile is similar to cataract surgery, and that's what I like best. What I like second best is that it works. And in most patients, we looked at this, we presented this at ASCRS last year. Patients that got cataract surgery plus an iStent dropped their pressure a little over 4 millimeters of mercury and on average get rid of almost the drop. But we also looked at pseudophakics that had already had their cataract out and put an iStent in, and those patients dropped about 4 millimeters of mercury and a half a bottle of a medication. And so it works, and it's worked well for my population, and we've got a lot of patients that help. I like that it's refractively neutral, so that you can do it in combination with toric lenses. I took care of an ophthalmologist recently who wanted to be spectacle independent. We took out his cataract, put in a toric lens, put in 2 iStents to help protect him from his glaucoma, and he was seeing great and off his medications and made a real big difference in his life. I think that the biggest challenge with the iStent is that I really want to use it even if a patient's glaucoma is severe, and so it may be that it doesn't get the pressure low enough when we need it, and we still have to go on to a trabeculectomy or a tube shunt. But I feel a lot better going to one of those more aggressive diseases knowing that I've tried everything conservatively and safe first. The other thing is that there's a learning curve, and it takes 10 to 20 cases to start to feel real comfortable with it, maybe sometimes even longer. And so a lot of times when people are starting out in their first 10, they may not get in a few of them, and that can be a frustrating start to it. And so it's important to kind of hang on and be diligent and get good at visualization and all that stuff. If you're doing cataract surgery on a patient that's on a glaucoma medication, you should really be thinking about doing the iStent, because you're doing your patient a real service by doing that.